Thank you very much for the kind invitation to the Serbian Neurosurgical Society. I apologize for giving this during a flight time, and I will not be there for the session itself. Dear Chairman, my topic is concomitant craniospinal injury, lessons from registry and public health studies in Scotland, 21st century. I have no financial disclosures. We will see how we can look at data from a variety of sources, and one of them is the use of registry data and linkage data. But let's start with the background. Head and spinal injury can cause a high burden of disease due to the long-term physical and mental disability. The anatomical and biomechanical relationships between the cranial and spinal structures makes concomitant injury likely. The quoted prevalence of concomitant cranial with spinal injury is variable, and this remains a relatively unexplored field with respect to long-term outcomes. In a previous systematic review where we have synthesized the evidence, we looked at those patients who had traumatic brain injury, and within that group, the prevalence of concomitant spinal injury was the following. 6.5% of those with TBI had cervical spinal injury. If it was a motor vehicle accident, 11.7% would have cervical spinal injury, but overall, 12.5% would have any spinal injury. In a different way of looking at these, we start with those that have a significant spinal injury and looked at the prevalence of associated head injury. And if patients presented with a cervical spine injury, 40% of those had a concomitant brain injury. And if we look at any spinal injury, 32.5% had a head injury. So in summary, it actually depends on whether we look as the primary population, those with head injury, or those with a spinal injury. And if we look at those with a spinal injury as the presenting complaint, the likelihood of an associated cervical or any spinal injury is a lot higher. Based on that, we went back to our tertiary center registry to look at the prevalence of this concomitant spinal injury. But again, we were limited by the fact that the registry was based on those admitted with traumatic brain injury. We looked at something called Ward Watcher database, which has all patients admitted to the Western General Hospital intensive care unit. We listed these patients over the last decade, and we analyzed clinical and radiological parameters. The total number of patients with head injury included in the project were 567. 85% did not have an associated spinal injury, which means 15% did. And those that had both cervical and thoracolumbar spinal injury amounted to 3.7%, whereas those that had only a cervical spine injury were 8.8%, and those that had a thoracolumbar injury alone with the head injury, 9.9%. If we look at the kind of trauma, 23% of concomitant spinal injuries come with high energy trauma, and 2.5% of the total population had this injury with low energy trauma. If we then look at the number of patients with TBI and low energy trauma, only 5 had concomitant spinal injuries. All those 5 patients had other risk factors, for example, history of alcohol excess and falls, and 1 had epilepsy and fell due to a seizure. If you look at the high energy trauma, Out of 343 high energy trauma with head injury, 80 of those, 23.3%, had also a spinal injury. 31.6% was after a motor vehicle accident, 26.4% after high energy falls, a small number, 3.6% after an assault, and only 6% after cycling injuries. Again, looking at the mechanism of injury for high energy trauma, motor vehicle accidents had a significant risk of having an associated concomitant spinal injury at any level, 31.6%. The risk for the cervical spine per se was 23%, thoracolumbar 16%, whereas if you compare that with the high energy falls, the numbers were a little bit less overall, a lot less in the cervical spine, but more in the thoracolumbar spine. So the next question that was born was, is the incidence of traumatic brain injury and spinal injury increasing or decreasing? And we were able to do this analysis by looking at public health intelligence data. And this slide shows the traumatic brain injury admissions by age. The bluish line clearly shows the hospital admissions with a diagnosis of traumatic brain injury are increasing year on year, especially in the age group of 65 plus. If we look at the annual percentage change of injury type, again, we see an increasing trend both for head injuries as well as spinal injuries, where the concomitant injuries at the bottom are more of a fluctuating annual pattern. This slide shows the percentage of admissions by injury type and age. And those under 16, you can see that head injuries are the commonest reason for admission amongst the three groups of head versus spine versus head and spine, whereas all the others seem to have more admissions for spinal groups rather than brain groups, apart from those over 85, where it's pretty much equal division. The concomitant injuries, which is the far right group, are ranging from 7.4% in the under 16s and coming down to 5.6% in the 80s, over 85s. In terms of gender, it is clear that the male gender is more commonly affected. And if we look at the length of stay per year by injury type, again, we have 6 years shown, 2014 to 2020, and we can see an increasing trend in pretty much all boxes for the duration studied. So the purple is less than 2 days hospitalization. The green is 3 to 7 days of hospitalization. The bluish color, 8 to 14 days of hospitalization, and the yellow, more than 2 weeks of hospitalization. So for concomitant spinal injuries, we can see that the length of hospitalization is definitely longer than all groups. In terms of the length of stay by injury type, those who stayed more than 14 days, we can see again, head injuries, 29.5%, the spinal injuries, 34.1%, whereas combined injuries, 46.3%. We uncovered a relationship between traumatic brain injury and socioeconomic disparities. And for this, we used a surrogate called the Scottish Index of Multiple Deprivation. On this, you will see that quintile 1, which is in blue, is the most deprived, and quintile 5 is the least deprived. So quintile 1 is the most deprived. Looking here, the traumatic brain injury admissions over the last 10 years, as per these index, the Scottish Index of Multiple Deprivation, quintile 1, in other words, the most deprived, is at the top of the curve, showing a higher annual percentage increase. And over the last 6 years, if we look at head injury by severity, again, quintile 1, in other words, the most deprived, exhibits higher incidence in all types of traumatic brain injury, major, moderate, or minor. Looking at trauma severity in 3 subgroups of cranial versus spinal versus craniospinal by socioeconomic class, shows that concomitant craniospinal trauma is more severe and commonest in the most deprived. In other words, the SIMD 1. These are quite concerning data because not only the number of head injuries and concomitant injuries is increasing in the lowest socioeconomic group, it is also more severe in that same group. On this graph, we can see again the 3 subgroups of head, spinal, and head plus spinal injury. Again, annual admissions by the quintile. And if you look at the top graph, blue line, class 1, which is the least affluent, the most deprived, have the highest number of annual admissions for head injuries. They also have the same number of admissions for spinal injuries. And again, in the bottom, the concomitant group, blue, the most deprived, again, the highest number of annual admissions. We can investigate this in many different ways. These are graphs that are showing the severity of injury in association with the socioeconomic class. And again, you can see class 1 is the highest in green, which is the minor injuries. It is the highest in orange, which is the moderate injuries, and it's the highest also in the major injuries depicted in red. How about the outcomes? Well, if we look at head injuries on the top left, the binary depiction here includes orange boxes, which are those that survive the head injuries, whereas the gray boxes are those that did not survive the head injury. And the majority of patients, the vast majority of patients, do survive. Same with spinal injuries, as expected, the risk to life is very small. But if we then compare the concomitant subgroup with head and spinal injury, it is clear that those who do not survive is significantly larger than the other groups. In a slightly more detail, taking all injury types together on the far left, 90% survived and 10% did not survive. If you look at head injury alone, 84% survival rate versus 15% mortality rate. The spinal injury alone, a 96% survival rate over the study period versus a 3% to 4% mortality rate. But if we look at the concomitant injury group on the far right, the survival rate drops significantly to 75% or 76% versus the mortality rate jumps up to 24%. So allowing for some limitations in the lack of granularity from public health data, we can conclude that concomitant craniospinal injury is a relatively unexplored field with respect to long-term outcomes. We can use registry, institutional, cohort, and national linkage data to gain some more insight into epidemiological trends and associations within limitations. But more detailed and more granularity can only be obtained with prospective design studies. I'd like to thank you for your attention and again for the invitation, and hopefully look forward to seeing you soon face to face.